Great. Ladies and gentlemen, welcome back to Equality, our international ground rounds. Pleased to have today a guest. Very difficult to set up the whole platform today. Our guest today is from Australia. I'm very pleased to have someone that I really appreciate, a very, very talented professor from Adelaide University. I'm glad to have today Alkis Psaltis from Australia. Good afternoon or good morning, Alkis.
Hi, Puya. Thank you very much for inviting me. It's afternoon here, and I understand it's morning in Italy.
Yes. We had some discussion with Alkis in regards to the topic today. Very interesting for the talk in regards to the management of recurrent polyposis and his the general personalized treatment strategy. And I'll remind all the attendees to remind that Professor Psaltis is going to present his talk. But in the meantime, if you have any questions, you can type it on the social platform and we will be able to respond to that. So Alkis, I request you to share your screen and go ahead with your presentation.
Fantastic. And thank you very much for this really kind invitation of yours to have me to present. So I'll just share my screen and can you see that there, Puya?
Yes.
Fantastic. Okay. So yeah, thanks very much for this opportunity. And I want to speak about a topic that I think is really relevant to us all as ENT surgeons. And it's probably one of the most frustrating conditions that we treat, because you can do good surgery, patients can do exactly what you tell them to do, and they can get recurrence of their polyps. And so it's actually not letting, okay, there you go. So look, when we look at nasal polyposis, there's, different types of polyps. There's a huge spectrum. We can go from having patients with very limited disease where we have central polyps only, central compartment syndrome, or we can have patients who have pansinusitis with complete opacification of all of their sinuses. And we know anecdotally from our own experience that patients on the top of the screen will do really well from surgery and will usually have a good long-term outcome. Whereas those patients at the bottom of the screen with widespread disease and possible aspirin exacerbated respiratory disease will do really badly no matter what you do. And so what I'm going to speak to you today is about how we should be looking at our patients individually, not simply, treating all patients with polyps the same, and basing our treatment strategies on the actual histopathology of the polyps themselves, and having a way of doing more than just steroids and surgery. Here we can see a patient who has had really good surgery. You can see on the CT scan, they've had complete removal of all their ethmoid cells. They've got widely patent maxillary sinuses. But despite that, they've got this really bad disease profile. And you can see this patient here where it almost looks like there's been no surgery done because the disease has returned the way it has. And these really are the frustrating patients that we deal with. So before we go into treatment strategies, let's look at the literature with regards to polyp recurrence. So this was a study done in our department and published back in 2012, where we looked at our own cohort of patients over a 10-year period. And we found that the rate of polyp recurrence was about 40% by the 3-year mark, with 20% getting recurrence within the first 12 months. Now, most of the recurrences occurred within the first 2 years following surgery. So 80% of patients who recurred had polyp regrowth in that first 2-year period, with 95%